And so there's some rules for these plans that the government doesn't have for themselves. One big one is called the minimum loss ratio, which means the insurance companies aren't allowed to make any more than 15% profit. But frankly, the insurance companies are exponentially better at being an insurance company than the government is. So they can take the same amount of money, make profit, and they still have money left over. And so they have to go, okay, how about some vision, or how about some hearing benefits, or how about silver sneakers, or until they get that scale back to where it's acceptable for the government. And so these kind of plans, HMOs oftentimes will include low monthly premiums, sometimes no monthly premiums. They'll also include extras. Sometimes they'll have vision, sometimes they'll have dental, sometimes they'll have hearing, some plans have transportation benefits. So that's what we get to the strengths and weaknesses of the plan. So most people in this room, if you're in a loan situation, this would be typically the only thing I would talk to you about. In fact, it's illegal for me to sell anyone on Medicaid a Med Sup, because your Medicaid does the same job, but it costs money instead of zero. So again, that's option one. Option two could be you could have Medicaid, and there are several levels of Medicaid. And so even if you have Medicaid, you probably don't know, but there's levels to it. And so there's QMB, there's QMB plus, there's a bunch of different acronyms because that's what the government likes is acronyms. Long story short, these are the three. If you have one of those three statuses as your eligibility level, you are what's known as a dual eligible. So you have Medicaid and Medicare. Any other level, LIS, partial, there's also QI. There's about 8 different levels that you should be at with Medicaid. I would be happy to help you evaluate which one you're at if you don't know already. So is anybody not 65 yet? Okay. Are you on disability? You're not on Medicare or anything? Okay, perfect. So now I will go through this. Okay. So to get Medicare, 65 or older, resident and citizen of the U.S., if you're a patriot who left and came back, or if you're establishing residency, you have to be here 5 consecutive years. At the end of that 5 consecutive years, a small window opens up for you to get Part A and Part B. So if anyone's in that situation, you have a 5-year window, and then it's right there. You want to get in touch with me very quickly at that point. Or you're in a special situation. So the special situations would be if you get SSDI, and that could be for anything. They do disability for quite a few different things. Could be mental, could be physical disabilities, other things like that. After you're on SSDI for 24 consecutive months, they automatically put you on Part A and Part B the first of that 25th month. End-stage renal disease is an instant ticket. If you get diagnosed with ESRD and you need dialysis, you have 90 days to contact and get in touch with Medicare to get Medicare instantly. ALS is another condition that you passed a 24-month exception for. Enrollment windows. So because of all of these kind of products, as far as Part A and Part B goes, they'll take you, whether you're the healthiest person running marathons, all the way down to on your deathbed with cancer. And everybody in between, doesn't matter who you are, what conditions you have, will take you. But in exchange for that open underwriting, they have to put time slots in. So the time slots are what are called enrollment periods. Your first one that you get hinges around your 65th birth month. It's the month of, 3 months before, and the 3 months after. The only exception to the rule is the first of the month. So if you're like me, I'm September 1st. If and when I make it to Medicare age and it's still around, I'll be 1 month earlier. So if you're the first of the month and you're aging in September, if you do everything on time, your Medicare will take for August 1st is when it will actually take effect. And so that's the one little hole. The government likes exceptions, likes loopholes, likes all that kind of stuff. I like to color code things to make them make more sense. What does green mean? Go. What does red mean? Bad, right? Okay. Green in this situation, it's government. Has anybody ever been to the DMV? Is anybody like me and you wake up a couple hours early and show up right at 7 a.m. when it opens? Be first in line? That's how I am too. So with the government, it's always best to do things sooner than later to give them time to make mistakes and process things incorrectly, right? So if you waited, so if you're a procrastinator, I know lots of those too, if you wait till your birth month or later, it pushes back your effective date. It could go all the way as 3 months. And so if you're September October, November, December, you wait till December 31st and then sign up, you actually won't be in effect until March 1st. So that can leave you with a 60-day period of what I call insurance nakedness, where you have your wallet protecting you. Anybody not living on a fixed income? We got to protect our wallets, right? If you miss your window, there's a general enrollment window every year, January 1st to March 31st. If you enroll in the GEP, coverage will not take effect until July 1st. So in another example, if somebody just missed their window now, the end of your window is at the end of this month. If you waited till next month to do something, you'd have to wait till January, and it wouldn't be enforced until next July. You'd have a whole year, at worst case scenario, of having to wait without coverage. And unfortunately, there are no other options. There is no short-term health. There is no Obamacare. There is no ACA. There's no options if you're over 65 and don't have Medicare. Part A. So what does Part A cover? It covers inpatient coverages. And so that could be at the hospital. It could be at the skilled nursing facility. It could be a home health care person that comes in and brings the nurse to you. There's a lot of things. If it's billed, and that's the key, how is the claim filed? How is it billed? Because there are situations, anyone stayed in the hospital overnight and then were told later that they were not inpatient? It's happening more and more. And what's going on, the Supreme Court just ruled that they're going to hear the case. But basically there's a class action suit saying that what hospitals are doing, Part A is losing money, government's losing money. So when they start losing money, they figure out ways to stop that bleeding. One thing they figured out is to create a bunch of paperwork and an audit process for facilities that do inpatient. And so anytime you're admitted as inpatient, that facility has to do 10 times the paperwork than if you were outpatient. So the government's kind of in a back way kind of created a situation where the hospital's kind of motivated to find a way for you to be outpatient versus just trying to treat what you're supposed to have happen. But there's lots of folks I've talked to. I slept there, I ate there, my family visited me there, but they said I wasn't inpatient. And the problem is, for skilled nursing, with A and B, you need a 3-day minimum hospital stay inpatient before skilled nursing benefits are covered. And so some people would get transferred to the skilled nursing because they need a nursing home or they need intensive care or they need something, and then they didn't have that minimum hospital stay, and then they stay in skilled nursing for 20 days, and they get a $40,000 bill. And so there's that gap. So it's important to me that you understand not just the strengths, because this is a great program. It does a lot of great things, and it's helped a lot of folks over the years, but it's not perfect. To get Part A and Part B, again, you can't be turned down because of medical history. You just have to enroll in the right time slot. If anyone travels outside the country, your Medicare stays behind with you. So if you do that, you definitely want to have yourself or your family member contact me because you want to get a travel policy in place for that situation. If you're collecting Social Security income, whether it's SSI early or SSDI, you're going to automatically be getting your card. Everybody else in the system has to sign up. So you're basically in that situation. If you're not collecting Social Security, you would have to then either go online or go in person to go sign up for Medicare. Standard premium this year is $134. It was the same last year. Unfortunately, Medicare's kind of treated like a bargaining chip with politicians. So this last couple of years, they didn't want to mess around with it. So Part B, deductible, premium, all that stuff stayed the same from 2017 into 2018. That's a rare event. I think it's happened twice in the whole time I've been doing this. No one's in this situation, but I have to tell you anyway. If you're a high income earner, above $85,000 as an individual or $170 as a couple, you pay a lot more for Part B. That's the key. 20% of infinity can be life-changing. And so most people don't just stay on Part A and Part B. What is Part B? Part B covers outpatient, which is basically everything else. Most things today are done on an outpatient basis. Heart surgeries, hip replacements, knee surgeries, most of that stuff's done outpatient unless we have complications. Brain surgery, transplants are the short list of guaranteed inpatient surgeries. Outside of that, most stuff's probably going to fall under outpatient. Outpatient works on Part B with $183 deductible. After that, it goes to 80/20 to infinity. Med subs, and so I'm going to breeze through med subs because med subs are not suitable for anybody in a loan situation. So I have to go through the information anyway, so I'm going to go through it as quickly as I can. You have to have Part A and Part B and live in the state for which you are applying. The window's different, so the government likes to be confusing as normal, so the window's different for med subs than it is for everything else. It would be your birth month plus 5 months instead of that 3 before, month of, and 3 months after. Doesn't make any sense, but that's how it works. The job of a med sub is to fill in some or all of the gaps that Part A and Part B leave. These are all the different plans they offer. For me personally, I only counsel and advise people for those 3. The rest of them, the difference in benefit for the premium difference that you exchanged isn't worth the value. And so for me, any client that I do with this is going to be high F or G. Prescription drug coverage. So this is the newest piece of the Medicare puzzle. Again, January 1st, 2006. A little over 12 years now is the program. Starting to iron out some of the kinks. And it's actually, in my opinion, this is a lifesaver for so many different people. And the reason I say that, and I mean that literally, what was happening before this kind of program came out is you're put in a situation, $300 for my prescription, no food, but I have my prescription, or food and no prescription. You have to pick food. And so people were, my mom was one of them. Take my blood pressure medicine on Monday, Wednesday, and Saturday, and I'll take this one on Tuesday. I'll stretch out this one prescription for 3 months. And so it's a great program, but there are still costs. And this is by far, prescription drugs is one of the biggest exposure points that you can have when it comes to costs. Yes?
Can you explain the donut?
We will get to that in just a moment. But I'm not allowed to call it that anymore. That's a dirty word for me. I have to call it the coverage gap. Okay? So, prescription costs. If you qualify for LIS, the low-income subsidy, or any level of Medicaid, the government's paying the premium for you. If not, then you have a premium somewhere between $20 to $100 and something a month. And there's 24 different standalone drug cards in Colorado this year. So, has anybody ever heard all your drugs on a tier 2 or tier 3 or tier 1? Tiering system. So the government has standardized this for the insurance companies. Higher the tier, higher the copay. That's the nuts and bolts of that. Keep it as simple as possible for you. If you have a high tier drug, I'll get to that in a second, but there are ways to drop tiers. So there's ways that I can help you get things more affordable if they're out of range. So I'm going to do my best not to make your brains blow up as I go through this, because again, this is the newest piece of Medicare, so it's by far the most moving part, convoluted thing you've ever seen in your life. There's in essence 3 buckets. First bucket's called the initial coverage stage, middle is called the coverage gap stage, last is catastrophic. The deductible, if there is one, and it's actually, I forgot to change that, it's $405 this year, going to a number I can't tell you until after October 1st next year. But standard design, if you have a deductible on your plan, you meet that first, and then between what you pay as a copay at the pharmacy, plus what your insurance company sends to the pharmacy to make them whole for that cost of the drug, that's the amount that goes to fill up this bucket. Once that amount gets above $3,750, you've now graduated into the next bucket, which is the coverage gap stage. And that's exactly what it is. There's a gap in coverage. Your health insurance no longer is covering your drugs. What's happening is the government's forcing those drug manufacturers that have signed an agreement with CMS to give a discount. So what's happening is you're getting a discount. You won't pay any more than 35% of the cost of name brand drugs, and you won't pay any more than 44% of the cost of generic drugs while you're in the gap. That's all what you pay to fill up this bucket. So of this bucket, a portion was the insurance company and a portion was out of your wallet. The portion out of your wallet carries over to this bucket. The rest of it stays over there. So it's only what you pay out of pocket. Once that true out of pocket hits $5,000, you're now in the catastrophic phase. And from then, for the rest of the year, you're in a 95-5 co-insurance split. Anybody think they can explain that back to me? Like I said, it's the most convoluted thing. What the easiest part of this is not try to understand this. Find an expert that knows what they're doing. Because I use databases and systems that help me do all of this work to tell you exactly this is how much your drugs will cost in January, February, March. I mean, it lays it out on a monthly basis. I can tell you exactly what you're supposed to pay.